Yes.
So there is one CME credit available for this lecture today. The event number is 44440. And then there's an address right there that you can claim the credit from. You have 30 days to collect your credit. So we want to make sure that you do that as soon as possible after this presentation. In the WebEx or Teams invite that you received is also a job aid on how to collect the credit and the link again with the event number. So you just have to also create, if you've never done this before, create a password using your first and last name, and then you will be able to get in and claim that credit for this session. So we ask that everybody puts their phones on mute so that we can dedicate our time to Dr. Vigilance. And I'm going to turn it over to Alicia Irving, our liaison, for the introduction. Alicia, are you there?
Looks like she's on mute. Alicia.
Alicia, can you take yourself off mute? Kathy, can we take her off of mute? Because she's saying she's not muted, but the icon's there. Kathy?
Yes, I see her muted as well.
Can you try to take her off mute when I do? Because I didn't open the session. I can't get her off mute.
Seemingly, I might do my own introduction here.
Yeah.
We'll give her another second. I'm not sure if there's anything else she wanted to mention before we get started, but if she's not able to get off mute, good day, everyone. My name is Deon Vigilance. I am currently the Chief of Cardiothoracic Surgery at Trinity Mid-Atlantic, the Fitzgerald campus. Also serve on the Penn Medicine campus as an assistant clinical professor of surgery. Also serve as the board president for the American Heart Association in Southeastern PA, and also another community organization Together for West Philadelphia. Also serve as the president of the board there. As a cardiac surgeon, specialize in all aspects of cardiac surgery, but really have a particular interest in valvular surgery, robotic cardiac surgery, and we'll focus a little bit on aortic valve today. I think there is a disease entity that's going to affect a large number of individuals in our community. It is the most common valvular heart disease in patients over the age of 65, and we'll see a significant number of those patients coming into the fold to receive a procedure or some type of intervention based on the fact of the new platform and technology we're able to apply to this disease entity. So I'll first get started by some basic definitions. This is stuff that we're all familiar with and we've all talked about a lot, but disparity is defined as a great difference, inequity, a lack of fairness or justice, and then discrimination, the unjust or prejudicial treatment or different categories of people or things, especially on the grounds of race, age, or gender. And then the new buzzword around town has been social determinants of health or social influencers of health. And these are conditions in the environment in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risk. So, in medicine, sometimes we think we're shielded from many things, but, I kind of pose a question as, in medicine, is there the presence of disparity? And the answer is yes, that's clear. There are instances of inequities, yes. Discrimination, no, there's no clear evidence to support this. However, patients' perception of discrimination can result in poor outcomes. So I'm going to give a little bit of personal reflection of how I got into this space. As previously mentioned, healthcare disparities are not new. However, the COVID-19 pandemic has brought forth discussions focused on disparities in healthcare affecting underserved communities of color. On a personal note, my focus on healthcare disparities began about 5 years ago when I relocated to Philadelphia from the Midwest. Two things were immediately apparent. One, most of my patients requiring open heart surgery presented for an urgent procedure through the emergency department. The second thing was most of my patients, once we got them into the hospital, required 2 to 3 days of medical optimization before undergoing an urgent cardiac procedure. This paradigm illustrated the importance of adequate maintenance, medical care in the community. As a result, I began volunteering in West Philadelphia, community-based organizations, mostly faith-based organizations, and ultimately became a board member of the American Heart Association and also Together for West Philadelphia. And as mentioned earlier, subsequently serving as current board president in these organizations. I share this background information in hopes that this presentation will stimulate some discussions centered around enhanced community-focused initiatives that will ultimately afford everyone an opportunity to live longer, healthier lives. A bit of backdrop for the first study we'll discuss, which was published earlier this year in January of 2021. A decade prior to this study being published, Healthy People 2010 final report highlighted race and ethnic health disparities as areas of concern. Following the release of this 2010 report, the U.S. Department of Health and Human Services action plan to reduce racial and ethnic health disparities was then first published the following year in April of 2011. The HHS Disparities Action Plan is the most comprehensive federal program to date aimed at eliminating race or racial disparities in healthcare in the United States. The current study, published earlier this year, was undertaken to ascertain whether or not this program is associated with a decrease in racial disparities in the use of major surgical procedures in the United States during the period of January 1st, 2012 to December 31st of 2017. The data was sourced from the National Inpatient Sample, NIS, which is the largest all-payer database for inpatient hospitalizations in the United States. So just kind of give you an overview of the type of procedures that they were considering as far as the surgical interventions. Selected procedure evaluated included PCI, percutaneous coronary artery intervention, spinal fusion, coronary artery bypass grafting, CABG, carotid endarterectomy, total hip replacement, total knee replacement, heart valve replacement, appendectomy, and colorectal resections. In this study, the race-adjusted procedural incidence was higher for white compared to Black patients for every procedure analyzed at every time point in the study for both men and women. What was a bit alarming is that the disparity widened for 3 procedures during which included total hip replacement, total knee replacement, and and heart valve replacement for both men and women. And I highlight this a little bit here so you can see while they were observing, and let me get a pointer here. While we were observing from 2012 to 2017, and you look at these three procedures, that there is a widening between these groups that underwent total hip replacement, total knee replacement, and valve procedure from 2012 to 2017, and it was both, again, with men and women. That was a bit, like I said, alarming to me, because you would think is why it's being observed, the trend would move in a positive direction, but it actually widened. Here's another illustration of the widening disparity for total hip replacement and heart valve replacement. This study reported that by 2017, white patients underwent double the race-adjusted incidence per 100,000 persons as related to heart valve replacement procedures when you compare white patients to Black patients. And as you can see here, that there is a widening of these two curves, white patient on the top, Black patient on the bottom, when comparing 2012 to 2017. Analysis of race-adjusted incidence of CABG, carotid artery endarterectomy, total hip replacement, and heart valve replacement by U.S. Census Division, comparing urban teaching hospitals with urban non-teaching hospitals. And, this is kind of important in the sense that a lot of the institutions around here, there are a lot of teaching hospitals and maybe less of the private hospitals when you kind of look at the total collections of hospitals in Philadelphia. So this was kind of important for me to really kind of hone in what's happening here. And what we've seen is that the rates were higher for white than Black patients for every procedure, in the groups that we examined. As far from a regional standpoint, when you're looking at patients from New England all the way to the Pacific Coast, these disparities were consistent, and they were even amplified in non-teaching hospitals. So if you look at the trends here, you can see that in teaching hospitals, there are definitely differences. But when you go to the non-teaching hospitals, those differences were actually amplified, with white patients being in the darker bars than Black patients being in the lighter bars. Particularly related to heart valve replacement surgery, greater differences between white and Black patients were shown in urban non-teaching hospitals, as illustrated in the lower graphs. Actually, this is the graph I really wanted to highlight a bit here. Again, white patients in the darker, Black patients in the lighter. And you can see that in these non-teaching hospitals, again, from the Northeast all the way to the Pacific Coast, the differences were significant, particularly in non-teaching hospitals. So why was this concerning? The existence of such disparities, especially concerning since the highest concentration of minority races typically reside in urban locations, and the latest medical technology and advances are typically deployed at teaching hospitals, also highly concentrated in urban settings. Well, you may say, well, maybe the difference here lies in the insurance and who is insured and who is not insured. And that does not seem to be the case. Among various insurance enrollees looking at Medicare, Medicaid, and private, the race-adjusted incidence was higher, almost twice as high, for white patients compared to Black patients for all procedures, with everyone being equally insured. So really, insurance did not tell the story of why we're seeing these differences. And again, as a surgeon, a heart surgeon, I was particularly focused on the differences as it relates to valve replacement. Well, I'm going to spend quite a few, the rest of the presentation kind of focused on aortic valve stenosis, because there's clear evidence that showed patients who go untreated after they develop symptoms, their outcomes are significantly poor. And this is based on this illustration. In 1968, Dr. Braunwald published a steep drop-off curve of survival following the development of symptoms in patients with severe aortic stenosis. And their life expectancy had significantly dropped and were expected to live about 2 to 5 years based upon which symptoms they presented with. So as you can see, if you presented with heart failure, you had about 2-year survival, which extended to about 5-year survival if you presented only with anginal symptoms. So that was pretty important and significant. Knowing this fact, what we do realize is that it's been well established that aortic valve replacement has significantly improved the prognosis and quality of life for patients who have aortic valve replacement procedures performed. It was quite interesting that 50 years later, during an interview in 2018, the same Dr. Braunwald commented, and I quote, it has been immensely interesting to me to have observed these advances, which have allowed a steady increasing number of patients with severe aortic stenosis to have entered the promised land. And he was referring to patients who are undergoing transcatheter aortic valve replacement compared to the traditional open operation. Unfortunately, these innovations have not been equally, end the quote after promised land. Unfortunately, these innovations have not been equally disseminated across the spectrum of patients afflicted with aortic stenosis. Multiple studies have shown the treatment disparity that particularly exists affecting patients who identified as minorities. I wonder if I can restart this. So I'm not going to, put any gory pictures of open heart surgery, but what I would like to do is play a short video which depicts the transcatheter aortic valve replacement procedure, which has a crimped valve loaded on a catheter, entering, making a small incision in the groin, placing a wire across the native stenotic aortic valve, and allowing that delivery system of that crimped aortic valve to replace the diseased native aortic valve using a very simple technique where you place the new transcatheter valve across the native valve, rapidly pace the heart, and then deploy the new valve in its place. The new valve is operational immediately. The delivery system is then retrieved, and the patient spends about a single day, maybe 2 days in the hospital, and then go home and resume normal activity, compared to having someone have to go through an open heart procedure, spending a week in the hospital, and being limited for several weeks to months sometimes after an open heart procedure. This is the study published in 2019 that highlighted certain facts we'll kind of briefly review. Racial minorities, or folks who identified as racial minorities, represent less than 10% of all patients undergoing surgical aortic valve replacement, or SAVR, in the United States. During the past decade, the introduction of transcatheter aortic valve replacement, TAVR, has revolutionized the treatment of aortic valve stenosis in the United States by expanding definitive therapy to many previously untreated patients. And just to give a little background, when we first started doing this procedure, it was really offered to patients who were considered high risk for surgical procedure. So we had a lot of patients entering into these trials and studies who would not otherwise have an aortic valve procedure performed. Over the last 10 years, we've gone from high-risk patients to doing transcatheter aortic valve replacement procedures in low-risk patients and patients as in their 40s and sometimes in their 50s, but even sometimes in their 40s. That's what happened over time. Then the question was asked, what are the racial disparities that were observed in surgical aortic valve replacement studies that were published, with those existing also in transcatheter aortic valve procedure? This study was designed to evaluate racial disparities in the performance and outcomes of transcatheter aortic valve replacement for patients undergoing the procedure between November 2011 and June of 2016. The American College of Cardiology, Society of Thoracic Surgery, and Transcatheter Valve Therapy Registry were utilized to identify all patients treated with commercially available TAVR valves in the United States during that time period. Here's a quick overview of the patient's demographics. First, I'd like to apologize about this being a bit of an eye chart. However, as we compare racial ethnic minorities, white patients were more likely to have private insurance, a lower STS risk score, lower prevalence of porcine aorta, and lower 5-minute walk test. And the 5-minute walk test is an evaluation of patients' frailty. There were no differences among the groups as it relates to the presence of moderate or severe chronic lung disease, median left ventricular ejection fraction, the frequency of tricuspid valve morphology. And the reason that tricuspid morphology was entered into this, or why it's important, is that if there is significant left heart failure, then you have transpulmonary pressure that exists and then ultimately results in tricuspid valve regurgitation. There was also no difference in the mean aortic valve gradient in these patients or among the groups. In the overall population, they looked at over 70,000 patients treated with TAVR during this time period at a total of 455 sites in the US. 91% of those 70,000 patients were white, 3.8% were Black, 3.4% were Hispanic, and 1.5% of those patients identified as Asian, Native Americans, or Pacific Islanders. This significant underrepresentation, and again, going back to this slide, you take a look at this and you can imagine that, again, we're still at, with transcatheter aortic valve replacement, less than 10% of all minority groups being treated with transcatheter aortic valve replacement intervention for aortic stenosis, very similar to that for the surgical open replacement. So what we know, again, is that based on the US Census data, people of Black or Hispanic race each represent about 9 to 10% of the population over the age of 65. Nevertheless, each of these race groups represent less than 4% of all patients undergoing transcatheter aortic valve replacement between 2012 and 2016 in the United States. This proportion remained consistent during the study period, with the exception of a slight increase in the group identified as Hispanic. And here you can see there went from about 2.4% in 2012 to 3.5% in 2017, at the end of 2016. And actually that difference was significant, with a p-value of 0.017. After risk adjustment, there was no difference in the rates of in-hospital mortality. And this is kind of looking at the results for this study, looking only at patients who underwent transcatheter aortic valve replacement in that period of time. There was no difference in the rate of in-hospital mortality, myocardial infarction, stroke, major bleeding, vascular complication, or new pacemaker requirement. among the 4 racial groups. At 1 year post-discharge outcomes, and this was linked to CMS data, which was available for 29,000 of those 70,000 patients who were initially enrolled in the study. And when we look at that subgroup, 29,000 patients, again, 93% of the patients were non-Hispanic white. 2.9% of the patients identified as being Black, and 2.6% of those patients identified as being Hispanic. 1.2% of those patients in the subgroup identified as being either Asian, Native American, or Pacific Islanders. And when comparing this subgroup with the white patients, Black and Hispanic patients had a similar cumulative incidence of adjusted all-cause mortality. So mortality was no different among the groups, the overall 70,000 group, initial group, or in the subgroup of 29,000 patients. These outcomes held true for adjusting for both clinical and social economical risk factors. Of note, heart failure readmission were significantly higher among Black and Hispanic patients, with an adjusted hazard ratio of 1.4 and a 95% confidence interval. So, 40 Black and Hispanic patients in turn were about 40% more likely to be readmitted for heart failure in that first year following discharge.
Dr. Vigilance, we lost your slides on the screen.
Oh, did that just happen?
Yeah, I think Jennifer's probably coming in to help you again.
All right.
And she is.
If you go to the team screen. So we stop sharing. Yeah, so just click there.
How are we doing now?
We're good. We're back on. Thank you.
Screen's back on. Did you just miss this slide, or was this a slide before that you were not seeing?
We missed, I think, probably the one previously.
Okay. Sorry about that. Oh. And I'm going to mute for a quick.
Exactly.
So was this the last slide you were seeing?
Yes.
Great. Sorry about that. So, the study conclusions, what were some of the things that were pulled from this? Number one, racial minorities are underrepresented among the patients undergoing transcatheter aortic valve replacement in the United States relative to their representation in the US population, and that remained consistent over time. Two, there are no significant differences in the adjusted rates of in-hospital mortality or major complications at 30 days or 1 year following the procedure. When comparing white patients, Black patients, Hispanic patients, or patients who are identified as Asian, Native American, or Pacific Islanders. At 1 year follow-up after transcatheter valve replacement, Hispanic and Black patients had similar all-cause mortality, but higher rates of readmission for heart failure compared to white patients. I'm going to shift to a different study here, and this study also represents some of the factors that might contribute to the disparity observed. A couple of things we kind of look at is, biology. Black patients had a lower prevalence of aortic valve stenosis compared with white patients. Second, patients of racial minority have may have less access to advanced intervention, although that is not because it was not shown in this study to be the case, but what they kind of presume could be a possibility. And lastly, a category of contributing factors that deals with biases and patients' preferences, including patients' health literacy and distrust in the medical system versus the potential systemic or individual healthcare providers' bias that may affect patients' referral to heart valve team for transcatheter aortic valve replacement. Sorry, I'm going to go back a little bit here. So this is a study here that was, again, published in JACC of 2019 that provided a multifactorial approach to improving access to valvular heart disease treatment in underserved community. As you can see, this approach requires involvement of the heart valve team, the health system, clinical research team, if you're an academic institution, primary care team, and the patient. So, everyone's involved to kind of move the needle in trying to have more patients get into the queue to receive transcatheter valve replacement. For the heart team, emphasis was placed on cultural awareness and communication. For the health system, the emphasis was placed on quality and performance measures to inform practice behaviors and community outreach. Efforts to close the clinical research gap for academic institutions should focus on improving access to phase 3 clinical trials and early access to novel technology. And finally, better access was the emphasis placed for patients to connect with their primary care providers in order to diagnose valvular disease as early as possible. Based on some of the work that I've done in the past and the interest that we noted across the nation, as a result of these well-documented disparities and a personal interest, we are currently looking at a partnership between medical device manufacturers in an effective way to reduce the ultimate disparity that exists as patients look to receive therapy for their aortic valve stenosis. Further together is a potential pilot program we're presently evaluating in an effort to reduce racial disparities in the treatment of aortic stenosis in Philadelphia. We utilized some information gathered from the 2019 US Census database. We actually estimated that the gross incidence of symptomatic severe aortic stenosis in Philadelphia County based on that data. This was achieved by taking the total population and multiplying it by 0.08%, which is the annual estimated gross incidence based on published reports and industry modeling to identify patients in a population that should develop severe symptomatic aortic stenosis. This calculation estimated an approximately 1,267 patients with severe symptomatic aortic stenosis annually that should be identified in Philadelphia County. We then identified the risk categories of this aortic stenosis population based on known percentage of high, intermediate, and low risk patients. So based on all the modeling that we have looked at, looking at a population of 1.6 million patients, we pulled out about 1,267 patients. Of those, we identified about 532 would be low risk, 240 would be intermediate risk, and close to 500 would be high risk patients. These patients are the ones we would like to focus on a little bit because those are the ones that probably if they're high risk for surgery, they're more likely to be candidates for a transcatheter therapy. And again, of the almost 1.6 million patients or residents of Philadelphia, I'm going to break this down a little bit by what we've seen with some of the demographics. So this is data from 2019. 52% of the patients were female, 42% were identified as African Americans. And of those identified as African Americans, that 42%, almost 25% of those patients lived in poverty. Based upon claim data that we looked at, 2,928 individuals were diagnosed with various degrees of aortic stenosis. On the previous slide, as I mentioned, about 1,267 patients should have been diagnosed with severe aortic stenosis requiring intervention. However, when we looked at claims data, and this revealed that in 2019, only 202 patients had aortic valve procedures, including 142 patients who underwent transcatheter procedure and 60 patients underwent surgical intervention. There's just one cautionary note about this. The data we examine is based on two sources, the US Census Bureau and Definitive Healthcare Database, which examines Medicare Part A only patients. So there are a certain number of patients that weren't captured in this database. And as a result, the numbers can be a little skewed. So this 202 patients probably might even be doubled from the database we did not examine. That being said, we'll take a closer look at the breakdown of that 202 patients that we have known data on. Of those 202 patients who underwent aortic valve intervention, if you take a look at the breakdown, with a SAVR group, we had 40 patients who underwent surgical repair and a total of 104 patients who underwent transcatheter replacement. Of this, only 18 patients of the 60 patients had surgical repair, and only 22% of all the patients who had TAVRs were identified as African Americans. Diagnosis, as who is being diagnosed with aortic stenosis from the claims data in Philadelphia, the majority of the patients, 62% of the patients, are identified as Caucasians, and only 30% of the patients identify as African Americans. And again, I wanted to point out some of the limitations of what we looked at. The data sourced for this evaluation is only Medicare Part A claims. These are hospital claims with a primary or secondary diagnosis of aortic stenosis, transcatheter aortic valve replacement, surgical aortic valve replacement. This data does not include Medicare Part B, Medicare Advantage claims, Medicaid claims, or private insurance claims. As a result, the numbers obtained for Philadelphia County are an underestimation of what the true numbers should be. And I really wanted to point out that, that's where we want to make sure that, someone may say, well, my institution did 200 TAVRs, and we know those numbers are lower, and that's the reason for that. So we came up with a proposed pilot of how we go about addressing, number one, the disparities that have been observed. The proposed pilot to identify and address disparities in the treatment of aortic stenosis in Philadelphia County will require a systemic approach with the assistance of both local and regional stakeholders. Identified stakeholders include implanters, so the surgeons, the interventional cardiologists, hospital executives, cardiovascular service line administrators, device manufacturers. Really important to all of this will be primary care providers and community leaders. We also think we need to engage some of the professional society and organizations, namely the American College of Cardiology, SDS, the Society of Thoracic Surgery, and the American Heart Association. And last but not least, some of our patient advocates and some of the folks in the community. You know, I like to kind of go over some takeaways and kind of really put this to a little bit of a close of why we're examining and evaluating some of these things as far as disparities. But more importantly, I identifying why there is such an underdiagnosis of aortic valve stenosis in the community in which we practice medicine. You know, it's unfortunate that today we can accurately predict a person's health based on factors such as their race, income, and even zip code. This, I think, is really unacceptable and should be of great concern to all of us as providers. I wrote an article, an editorial in the Philadelphia Inquirer where we looked at, you know, life expectancy in Philadelphia. And if you take a trip from, you know, Strawberry Mansion to Society Hill, the life expectancy is a 20-year gap, with the average life expectancy in Strawberry Mansion being about, 68 years and going up to 88 years in Society Hill. And those regions in this city is about, you know, it's about 5 miles apart, and you have a 20-year difference in life expectancy. And I think, you know, something to be said about how difficult that is to come to terms with. So in closing, I'd like to leave you with a few takeaways. We can all work on, in an effort to narrow the what we define as narrowing the gap between underserved populations and looking at some of these disparities that previously discussed. My interest has been particularly in surgical aortic valve replacement and transcatheter aortic valve replacement. But this, again, spans many different areas in medicine that we can close the gap. The first thing we probably can do is implementation of measured quality improvement programs to address some of these identified disparities. I think one of the things that's been not talked about as much and probably now come into focus is how do we provide effective cultural communication with some of the patient population we're dealing with as approach for trying to close that gap. I think part of the sensitivity that we as healthcare providers need to have is how do we address some of the folks' issues and meet them where they are by providing adequate education and effective communication. I think early diagnosis is also paramount to the success of a program like this. And for some of the academic institutions, how do we change some of the research paradigms that are in place? We're getting some of these innovative technology in the pipeline to some of these underserved population. And I cannot highlight, you know, what access to care means and how do we kind of work with some of our primary care providers to improve access. At that point now, I'm going to probably stop and allow for us to ask some questions and leave some time for some comments. So I'm going to pause here and open up the floor for questions and comments.
Thanks so much, Dr. Vigilance. Does anyone, Cheryl, I see you raising your hand. Kathy, can you unmute the lines? There we go, Cheryl.
Yeah.
Go ahead.
Hi, thank you for your, Dr. Vigilance, for your talk. I'm a primary care provider. I think we met at Mercy Senior Health. And so as a primary care provider, you know, we identify the murmur. We refer to the cardiologist. And really the cardiologist would be the one who takes it from there in terms of, you know, making the referral to the cardiothoracic surgeon or treatment plans. You know, whether or not TAVR is you know, it's appropriate or not. So from a primary care perspective, where's our advocacy regarding our patients, and really who, you know, is this a primary cardiologist who advocates for the patients in terms of the appropriateness of procedure or to address these disparities?
Great question. Thank you for your question. So, you know, what we have done, and most centers, what they have developed is, if you identify a patient as having aortic stenosis, regardless of where they are on that continuum of having mild, moderate, or severe aortic stenosis, we would love to see them in our valve clinic. A lot of the procedures when it comes to transcatheter aortic valve replacement, and I see Dr. Wise is here on the call, we do this on the Penn campus. And since you don't have that platform set up here at Fitz, it's either done over at Presby or we have a team at Chester County, Penn Medicine Chester County Hospital. And it's really a surgical team, a collaborative approach. Typically we have an interventional cardiologist, the cardiologist, and the surgeons all working together in our valve clinic to see these patients. So really, we would love to take the responsibility of following those patients and deciding based on patient symptomatology, and that will determine when we actually get patients into the queue to undergo such a procedure. So if it's a difficult thing for the primary care doctor to say, I don't know when I should refer, it's never too soon to refer those patients to our valve clinic. And we would love to take on the responsibility of following them, deciding when it's the appropriate time to intervene. I hope that answers your question. If not, please,
Well, just from our perspective, usually when we refer them, we hear murmur, but we have to do the evaluation. So we send them to cardiology for the the initial workup, the echo, etc. So I think from our perspective, we think that that's handled, right? And cardiology will make the appropriate referrals. So, because I think it's not in our, but thanks for bringing it to the forefront that you have a valve clinic. But I think there may be some education around primary care and cardiology in terms of how to best funnel these patients to the right place so that we don't have that, clinical inertia that sometimes is seen, but that you just continue to wait until the patient becomes symptomatic and then it's not appropriate for the procedure.
I think I totally agree with you. I think that's been some of the barriers why some of these patients in the past don't come to see us or have a procedure performed, whether it's surgical or catheter based. My recommendation, and again, to take the burden off of the primary care provider, is to get those patients into a valve clinic. I think, not to bypass anyone at all, but I think one of the things and we typically run a valve clinic here on the Fitz campus. We have a valve clinic over at Presby. We have a valve clinic over at Chester County. We would love to see those patients. And we have many primary care physicians referring directly to the valve clinic because they know we have a comprehensive team who will see that patient, both from the cardiologist, general cardiologist, interventional cardiologist, and the surgeon who would all be willing to see that patient at the same time and come with a treatment plan that we think is appropriate for that patient. And clearly, one of the things we pride ourselves on is communicating those findings and plan of care to the primary care, the referring doctor.
Okay, thank you.
Any other questions for Dr. Vigilance? All right. Well, thank you for your time this afternoon. Just a couple of housekeeping things. There's 2 team members online with your phone numbers. If you can just in the chat give us your names so we can write it on the attendance sheet. That sheet gets submitted for those credits, so that way we make sure that when you go into that link that's in the WebEx or Teams invite, go to the job aid, click on the link, put your name in, and then the ID code 44440 for today's session, we can make sure that everybody gets credit. And just a reminder, you have 30 days to go in and retrieve that CME credit for this session today. So once again, thank you, Dr. Vigilance, for your time and everyone this afternoon, and have a great weekend.
Thank you. Thank you all.
Thank you.
Thank you.
Thank you, Doctor.
Thank you.
Thank you.